Hi, I'm Daniel Nyman. On behalf of the Forum for Healthcare Strategists, as well as our partners at Pariah Health, welcome and thank you for joining us for Customer Experience, a call to action for healthcare marketers. Increasingly, healthcare marketing executives are assuming responsibility for functions around consumer, patient, physician, and staff experience. And who better than the marketing leader to become the voice of customers, both within and outside of the organization, to bridge the gap between clinical services and patient needs. In today's webinar, you'll hear from 4 healthcare marketing and digital leaders who are tackling these new responsibilities head on. You'll learn how they're adapting strategies, tools, processes, and more to prioritize the expectations of healthcare consumers and turn experience into competitive advantage. One quick note before we begin. If you'd like to ask a question, please enter it into the question and answer pane located on the bottom of your screen at any time. Our panelists will respond to as many questions as they can in the time we have. With that, I'll turn the program over to Justin Dearborn, founder and CEO of Pariah Health, who will be leading today's discussion. Justin?
Thank you, Daniel. Very excited to be here today hosting this. So we have a huge turnout for the webinar, which is wonderful to see and expected given the great panel we have. So I'm going to go around and ask the panelists to introduce themselves because I can't do it justice. And maybe we'll do it in alphabetical order by first name. So Craig, if you wouldn't mind kicking off a little introduction.
No problem. My name is Craig Karchner. I'm the Chief Marketing and Customer Engagement Officer at Honor Health, which is a 9-hospital system in and around Phoenix, Arizona.
Thank you. Crystal, would you mind?
Hey, everybody. I'm Crystal Broy. I'm the Chief Digital Transformation Officer at the Medical University of South Carolina in Charleston. I'm excited to be here and talk digital and marketing.
Thank you. Jeremy.
Thanks, Justin. Jeremy Rogers. I lead digital marketing and experience at IU Health in Indiana.
You, Nardeep.
Hi, good morning. My name is Nardeep Singh. I'm the manager of marketing technology at Renown Health, and I'm excited to be here with you guys today.
Great. Well, again, thank you for spending some time this morning with us. I'm going to jump right into it and start with an increasing trend where healthcare marketing executives are assuming, and maybe some of you already have assumed this already, but assuming more of a role and responsibility for consumer, patient, physician, and staff experiences. And curious, what experience-related tasks do each of you have responsibility for? And how does it really fit in with other areas of, I'll say, more traditional responsibility? And maybe we'll just stick with the same order for this question. Craig, if you wouldn't mind kicking off there.
Sure. It's not very well defined, honestly, customer experience at Honor Health. And I think that has pros and cons. It's good and bad. We have a formal patient experience officer and then a consumer engagement officer, but customer experience kind of gets lost in the shuffle. The great thing about that is we work very well cross-functionally. We have a group that focuses on customer experience or consumer experience that is very cross-functional. I've never worked in an organization that has so effectively broken down barriers between marketing and IT and medical group leadership and finance because we've had to, otherwise nothing gets done. The downside of it, of course, is that when you have 8 department heads who are leading something, then really no one is leading it. There's no single person leading it. And so it does lead sometimes to some indecisions and differences of opinion that cause some hiccups sometimes. So that's how it is at Honor Health.
Great. Crystal?
Yeah, we are the same way. It's sort of, digital experience, digital front door sort of falls under my realm, but I work very closely with marketing because they own the website, so I can't do anything without working well with them. But we are hiring a chief experience officer that's going to be in charge of both patient experience as well as staff and provider experience. So looking forward to him actually joining us next month and anticipate that our 2 teams will work very, very closely together in that area.
So Crystal, will the web people, will they all report up to that new experience leader?
Well, people still report to marketing. So it's, and I from friends that I've talked about around the country, marketing can sit in a bunch of different places. Web marketing can sit under IT, it can sit under marketing. You just, every system's a little different on that. So in web marketing and digital front door are two different places too. And I don't report in IT, I don't report to marketing, but yet I have the toys that have to plug in and make those runs. So that's kind of how we run here at MUSC.
Great. Jeremy.
Yeah, Justin, I would echo a lot of what Craig and Crystal said. I mean, we've been through various incarnations. I've been here for 8 years now. We do have a formal patient experience team. They go by patient and family engagement these days. My team, you saw my title, I've got both marketing and experience responsibilities. And people ask, what does that look like? It's kind of a left brain, right brain situation. So we support the entire customer journey. So a lot of people fixate on the care experience. You know, we're across the journey, pre-care, post-care, everything in between. But we are very, very focused on consumer and patient experiences. We do support, clinical experiences for providers and their caregivers, for internal team members. Like we were responsible. We relaunched our intranet a few years ago because we have capabilities and skills, but it's not really what I would call our day job. Our day job is the consumer and patient experience, period.
Yeah, perfect. And Nardeep, what do you guys think about it?
Yeah, I agree with what the group is saying. I joined Renown about 2.5 years ago, and I come from hospitality and retail, which everything is consumer experience, patient experience, and that's what we do when we talk about operations and marketing. And when I arrived, I remember, different areas from our team wanted to focus on consumer experience and the customer experience. But what I've seen in the past 2 years is our senior leadership has done a really good job on communicating, and focusing and leading with data. So we've actually this year we've done a lot of transformation in our technology. We're focusing a lot on reviewing our technology tech stack and working within different departments, not just within marketing. We talk to the customer engagement team, we talk to operations team, we're in communication with our medical staff team as well. And we're seeing really great results, again, on reviewing our marketing tech stack, on implementation for this year. We have multiple projects going live, and we're already seeing some improvement. We went live with open scheduling for primary care a few weeks ago, and we saw, I think, a 28% increase on self-scheduling. So I think when you work together as a team and you bring marketing, communication, customer experience, and operations, you can see big results.
Great. We get applause from Jeremy there. And everyone is smiling on that one. Great results. Nardeep, I'll stick with you for a minute. And you touched maybe a little bit on this, but if you are adapting, how are you adapting some of the marketing strategies to address maybe the emphasis or more emphasis on consumer and patient experience with some of your other marketing priorities? And have you guys thought about building business case for that? Yeah, if you could comment on that.
Yeah. Again, we're having a really good year on communication across multiple departments. I think everybody's on the same page. Coming from hospitality and retail, this is what we do, right? We focus on our technical tools. As Crystal mentioned, I manage the website, and you start with the website, right? That's the digital front door. That's how you capture people. People are on their phones. So what we want to do with our strategy is focus on that effortless experience, which is easy to say, but it's really complex, right, in healthcare. But some of the stuff that we're doing is we want to minimize, channel switching. So we're focusing on if people prefer to be contacted in a certain way, let's say text messages or email, we're trying to do the infrastructure to do that. And we actually did the first stages of that this year already. We're trying to focus on maybe avoiding the next issue, right? Focusing on that hospitality background of customer experience. So avoiding the next issue. So again, making it easy for them to book. If you go online and you're trying to find information, making sure that the information is easy and accessible. If we have, we use different tools within our website. For instance, our Find a Doc, which we're doing some work on refining it and making sure that the search usability of the website makes sense for the patients. So focusing on them not being lost on all the information or booking with the wrong provider or putting information on, insurance information that they need to do to avoid them maybe booking, the wrong appointment or getting the wrong information, and then you're trying to backtrack and trying to, give them customer experience by fixing an issue. So we're trying to avoid it ahead of time, right? Meeting people with the preference that they want. And then focusing a lot on communication. So we have our department is divided. We have marketing, communications, and web. And we all roll up to the same directors. So we focus a lot on internal communication. So if we're going to have a new initiative, we make sure that our providers, our frontline staff knows what's going on. So when the patient or consumer comes to, our hospitals and clinic, everybody knows what's going on. Again, easier said than done, but so far, like I said, we're having a really good year on communication and strategy, and we're seeing the results.
Great. And then just one follow-up there on the business case side. Are these now being considered more table stakes, or are you still building out kind of formal business cases to, get the support internally to fund and roll out some of these initiatives?
So I've been here two and a half years. When I started, I know that they were doing the business case. So I was new and I was hearing this big project that they wanted to do for the customer engagement project, which was reviewing several of our digital tools. And now we've seen some again, like I feel like the whole team is on the same page. It didn't take the 2 years. It took probably a year and a half, but it was a really big project that involved IT, customer engagement, marketing, operations, our medical staff, and we did it in a phased approach. So we're not making the business case. I think everybody's on the same page. And again, because we did this phased approach, we were able to show progress. So the buy-in increased over time as well.
Great, thank you. Greg, can I put you on the spot? Same question?
Of course you can. So just like in, back in the day when you're looking at patient experience, you focus on the transitions of care. That's when things sometimes tend to fall apart. And so you look at when you're transferring from one unit to another, at shift change, those transitions. It's similar in the way we've approached things, where we look at most of the time, the patient experience, the customer experience, and the provider experience, the physician experience align. They want the same things. They approach things similarly, right? As a team, ideally. So it's when they don't align, when they want different things, we've tried to focus on those points, because that's where we can really make a difference in smoothing the experience for both the physician and the patient and family. So it's things like scheduling, access to care. Physicians and others don't want us to crash their schedule and to dictate what they do. They feel like they have so little control anymore that's their last vestige of control, is their schedule. And so they don't want that to be ripped away from them. But patients want easy online scheduling. They want to be able to get in when they want to get in. So we've really focused intently on that. So working very closely, relationship building with physicians and their teams. And one thing we've done that's made a massive difference in online scheduling specifically, I'll say two things. One is we have gone site by site to basically all of our clinics by now to meet with physicians and their staff. And we bring the experts from like Cadence, that's the Epic system we use for scheduling, right? So we bring the IT and other folks who really know the back end, and they talk through all the guardrails. They talk through the decision trees and the blocks in the schedules, et cetera, et cetera. So they are making it very clear from the get-go to the physicians that, look, we are all about protecting your time and giving you customizability. And when they can speak very concretely to the specific things they're doing in Cadence, it's clear they know what they're talking about. That is so reassuring for the physicians and their staff. It's made a huge difference. And then we can open it up more and more. And we notice that there's very little complaint from the physicians. A lot of the times they were worried for nothing. And with the proper guardrails, it's just been a non-issue, and patients absolutely love it. So another thing we've done is try to message, this is the marketing side, try to message as prominently as we can that you, the patient, it's really important to have a relationship with your primary care provider, but everyone knows you're not going to get in. It's difficult to get in next day. It doesn't mean you shouldn't schedule it. Even if it's 6 weeks out, schedule it And then there are other things we can do in the meantime. So we've really pushed e-visits, asynchronous visits, and the Saturday clinics and evening clinics. And we have a virtual team, care team that works specifically in our call center. They're on staff at the call center. So as the agents are talking to patients, they can ascertain this really needs a caregiver now, like we don't want to wait. And it doesn't displace that appointment that the patient is set 4 weeks out. It's just helping them in the meantime. And so that messaging and finessing and flexibility has made a really, really big difference. And we've noticed both patient and physician experience scores climb.
I think that's really unique, Craig, that you have that some staff right in with your patient access center so that you can, transfer that call if somebody really needs it. I think that's amazing. I think that we have a lot of things in our area too, where we're trying to go to those asynchronous visits or serve that up. And from a digital front door perspective, we've got a Get Care Now button on our main page so that patients can figure out how to do that. There's find a doctor or make an appointment. Then there's Get Care Now, and then we move it into, here's an asynchronous visit you can do. Here's a video visit you can do. Here's a video visit with some specialties that we also have. Or, by the way, here's how you get to urgent clinics and ERs all in one space, and then try to triage. There's some information below so that they understand. Not everybody understands what an asynchronous visit is either at this point. So it's like text your doctor, get response within 30 minutes, blah, 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 that kind of stuff. So we've really taken that and then tying it back to how we're changing our marketing, Justin. Our marketing team is supporting that because we're trying to push people more to asynchronous, trying to get people to not go to the ED for general care, which they're doing because we have an access issue, just like everyone else across the country. But we do have people waiting to take that call so that they can help you virtually. Our marketing team is so amazing. They're actually saying Get Care Now, and they're putting it on the wrappers of all of our buses so that with a QR code so that people can take a picture of it and actually then go straight to that website. So when we go hand in hand with marketing, we could really make a change. Buses coming out in Charleston in another month or so. So if you're down here, watch for them.
Crystal, let me ask you how you pay your physicians so that async visits come in. Who reads them, provides a diagnosis and prescriptions and whatever, and how do you pay whoever that is?
We have a separate staff. It's separate from our brick and mortar docs. That's it. We have we're one of 2 centers of telehealth in the country. And so we have a very big virtual care department that takes care of that on that side.
Is that the organization you just kind of stood up and announced, or is that, am I confusing it with something else?
Are you speaking of Ovation?
Yes.
Ovation is virtual care that is video visits. They're an adjunct. We will share how physicians with Metro Health, and they'll be able to practice in both places, so that we can add on to our team and extend the amount of reach we have and provide that access for our patients.
I asked Crystal because we made the mistake when we stood up our e-visit and even virtual visits to an extent that call center based team. We started by using regular, quote unquote, regular medical group clinicians, and it failed pretty catastrophically, right? There's no incentive to provide the care, and they were just frustrated and felt like we were taking advantage of them, and we were. So as soon as we started paying them on a PRN basis, or paying them, per read or per episode, it changed immediately. We had people coming out of the woodworks to volunteer, physicians coming out of the woodworks to volunteer to staff these things and to read the e-visits, and it made a huge difference. So you figured it out faster than we did.
You're getting paid. Is it really volunteering though, my friend?
Correct.
I get your vibe, but they're technically being paid, right? There is a financial incentive, correct?
Yeah. So before they were just being paid their salary, and maybe they have an RVU bonus or something.
I'm just messing with you. I know exactly what you mean.
Okay.
No, so Justin, we've had similar challenges. I think everything my colleagues here have said is accurate for us too. Even on Crystal's example for async, we are not an Epic shop, so we don't have an e-visit capability out of the box in the EMR. So on the ROI piece, it's very challenging to justify greenfield new dollars to stand up a new platform for that. From, you guys know reimbursement's tricky in that space. Is it cash on the barrel, things like that. So we've dabbled, but not really scaled it. On the first part of the question, we are fortunate because we are part of the broader marketing team. So we are very integrated into all of our brand planning and service line planning. So from day one, in terms of looking at SWOT analysis and external realities, the market conditions, my team is in those meetings. You know, it's often a push and a pull. There may be situations where we have deployed new capabilities and we're offering those up, we're injecting those into a marketing tactic or a marketing strategy. There's also the opposite where the brand marketing team has identified, hey, we have a campaign need or a local need. Can we deploy new capabilities in those areas? So it's a really kind of a virtuous relationship there. You know, we've been pushing that boulder uphill for several years now. Most situations I see now are less about deploying new technology. Like most of you, we have new tech coming out of our ears. It's change management, the back office, like, do we have operational support for these things? So we don't often get someone asking us whiz bang new tech off the shelf.
Great. Well, maybe hearing what you just said, I'm going to stick with that topic on digital tools, and I'm going to flip back to Crystal, who I know spends a fair bit of time evaluating digital tools. So regarding consumer experience specifically, are there a set of digital tools you think are necessary, and how you've gone about evaluating those and then deploying those effectively? And I know you guys are doing some of that, and I know you've looked at quite a few.
Yeah, we have a bunch that we started working with. We have an RPA tool that we use to send messages from, you know, when you have an appointment, it automatically sends a message to a text or an email to our patient saying, hey, you've got an appointment in 3 days. Do you want to confirm? Do you want to cancel? Soon it'll reschedule as well. And then it'll take them through filling out all the documentation, grab your insurance card, grab your driver's license, tell you what your copay is so you can pay ahead of time. So it does all that ahead of time. Same RPA tool then we use also for care gap outreach. So one thing that we've been really successful with in Charleston is for breast cancer outreach. When we turned that on, we started sending reminders to women that had missed a mammogram for over a year, and a lot have because COVID, people stopped coming. That we had within one night, we had 150 women schedule their mammograms, and within several months, we had over 2,000 mammograms scheduled. And since we started that program in February, we've had 169 women that actually had abnormal results. And with that, they were able to get additional help. So, you know, this is a place where tech is actually really saving lives, which is pretty exciting. You start moving from that to AI and thinking about, you know, the stuff that, you know, what helps providers and how, and that kind of stuff. And somebody put that in the chat and I was just answering back to her, but, you know, no provider ever went to school and said, gee, when I get out, I want to take care of patients and I can't wait to type into the EHR, right? Nobody ever did that. So what we need to do is start making it easier. And there are AI tools and other things now that can do ambient listening and then start to record all those notes for the doctors. There's AI that's going through and helping people write their note, their inbox messages and sort them and do some stuff with that to try to take that burden away. There's some really cool clinical support tools now that, you know, there's so much data right now in the space that no doctor can read, you know, the amount of data that's coming out. So I'm presenting with this, and this. What could that be? Do I need to send her to a specialist, or is there something that I can do here for her? And that also helps with access, Craig, because if a primary care physician can take that and we're not sending them for a referral to the brain surgeon when it's just a different type of migraine that primary care has never seen before, that helps the entire system work. So that's a great tool. We're using voice bots, but we just put a voice bot in our patient access center. So about 18% of our calls are now answered and totally 100% without a person with our voice bot, which lets our patient access center people handle the more difficult calls, right? You can call, we get calls that is my appointment today or tomorrow, or where do I park, or things like that. That doesn't need to go to a human. We can moderate that. I want to confirm my appointment. I want to cancel my appointment. And again, soon to be rescheduled. Those things can just be handled by a bot. So then when it's like, I need to book my brain tumor surgery, but I need to get an MRI and this and this and this. Well, that has to stack. That you need a person for. AI is good. It's just not that good yet. But every time we bring a tool in, we first, you know, we have to see, does the EMR that we have do it? You know, we always try to do that first because we already have it. Why would we buy something new? How difficult is the lift going to be? You have to review what kind of, you know, ROI. We can't buy anything unless we can prove that it's going to have a true ROI for our system. because these things are not cheap, and they're not cheap just because of the cost. The amount of time, like Jeremy was saying, to do the change management and follow it through and do the communication and the training and the planning and maybe change templates on the back end, or just the connection with IT. Everybody's IT services right now are just overburdened. And so we keep wanting to plug stuff in to be the cool kids on the block, but IT can't keep up with that. They're still trying to keep the lights on and upgrade our EMR and do all those kind of things too. So there's a lot to evaluating these tools that help the patient experience to make them go to life.
Great. Jeremy, any thoughts there?
No, Crystal said it well. I mean, I think similar experience here. Like I said before, we're not deploying a lot of new tech. We have, I mean, we have kind of like death by point solution today because of the EMR situation is just the reality. So a lot of it is rationalizing, you know, the various platforms we have. There's this Venn diagram. Who does what? Who does it best? Who does it cheapest? Who's strategically aligned with where we're going to go in the future? We have a lot of those conversations. A lot of my team's focus is again on kind of rounding the curves, like Craig mentioned earlier, like those transitions in care, we call them moments that matter. That's where we tend to go really deep, because those are areas where typically the EMR doesn't have great experiences, great solutions. So we go deep and heavy there. That may require, you know, it's different integration. It's the data Crystal mentioned. I mean, we have most of these tools in our toolbox. It's how we deploy them, how we orchestrate them. And what I, you know, looking across the industry, I don't see a lot of people proactively orchestrating experiences. It's very, our industry is very reactive, less proactive. I want to see a lot more proactivity in terms of how do we delight patients, providers, team members, because we have all the tools to do that. It's just how do we do it, and how do we get out of like fighting fires every day? So we tend to focus on that in our long range planning to make sure that's where we want to go. But it's not easy. It's mud wrestling and arm wrestling every day. It's just the reality.
You know, I have again a question for Crystal. I feel like I'm picking on Crystal. Maybe it's just because sorry, Crystal, don't mean to pick on you, but we are looking at, I loved what you were saying about the ambient listening and using tools to make the physician experience easier, AI based and other tech to make their experience better. We're doing the same thing. We've done some research, and we have more research slated among consumers and physicians on how they feel about AI. At what point in the journey is it appropriate to have AI intervene, and in what fashion? Is it just for clerical work, or are you comfortable with clinical work? How about passive clinical, like ambient listening in a room, an exam room, versus, you know, active involvement in the decision-making process or in diagnosis, et cetera, et cetera. And we've seen absolutely there's a lot of polarity. It is not consistent what we're hearing from at least from consumers. Physicians are a little more consistent, but from consumers, it's not at all consistent. Some people are really worried. So how have you gotten around that? We've tried to offer preferences and opt-ins and make sure people are comfortable, but that doesn't always work with some tech, like the ambient listening that is not easy to turn on and off. So what have you done?
So we actually, the provider comes in and says, hey, I've got this tool that will help me take notes. Are you okay with me using this or not? And then if, you know, you have a patient that's like, wait a minute, it's going to go to the sky, you're going to have all this. No, I don't want that. Then, you know, we don't, and we do it the other way. But we also send surveys to patients, go, we understand you had an experience with this. How did you like it? And we're getting really high patient satisfaction. They're like, we felt the doctor spent more time with us. We had a better conversation. It was much richer and so on. We also do the same with the providers. Is it easier? Is it whatever? You know, we have pajama time. That's the time from 5 o'clock on when they're not actually seeing patients. That's gone down, you know, 30%. We're closing charts faster, which is better both for a patient and the health system and the doctor, because then it's not sitting out for several weeks. And then, you know, like 12% faster or something. I don't have the numbers in front of me, but we're just seeing really good success with ambient listening for that. We also did similar stuff with a whole survey of South Carolinians going, how do you feel about this? And it varies. They're much more excited about it taking over some of the back office stuff. They're okay with the ambient listening, but like they don't want it making clinical decisions.
Yeah,
Um,
that's,
it's-
we
which
found
is
that too.
expected. And what we always say is when you're using AI, there has to be a person in the mix. You can't, AI is never going to replace a doctor. It's never going to replace it. You always have to go and look at it. Consider it like an intern, right? They're your co-pilot. They're helping you do some of the lifting. At the end of the day, if you ask an intern to write a report for you, you're not going to submit it to the CEO without reading it over first. Same thing with AI. You've got to look and see what is it suggesting, because sometimes they get it wrong. And you want to make sure that you have it right. And it may still, while it may give you the facts, it may not say it in the way you want it to say. And so you're still going to have to massage that. And I don't see that changing anytime soon. It doesn't matter what the language model is.
We've also done it. Our experience mirrors yours, and we've gotten positive feedback too. The other thing that's been very effective for us is the inbox inbox messages management of that tool. So we've used AI to help draft responses to patients, and then the MA is the first one to review. So it doesn't necessarily hit the physician, in their pajama time, like you said. And that's been incredibly successful. Patients usually don't even know, although we do disclose it, but they don't even know, and they're getting messages much faster, so they're happier, and the pajama time is reduced. So that's been another hugely successful thing. So,
And AI says it in a more softer,
isn't
nicer
that
way.
crazy?
Because if a doctor's having to go through 100 inbox messages, go, yep, just take this, or yep, you're on the right track. The other one, if you use AI, it's like, I'm sorry you're not feeling well, Crystal.
Yeah.
Things that you can try. Hope you have a good day. Let me know if you need anything else. Doctor be like, yep, up. And they know it, but they don't have the time for it. And AI just gives you that nice, warm, fuzzy feeling, which is also very fun.
I know it's crazy to me that that's true. It's just nuts to think that it is true, but the AI has infinite patience. Humans have limited patience, even at the best of times. So you're totally right. Crystal, something else you said triggered something in my brain, and I hate bringing up a study that I can't specifically cite, but I can find it. It was early this year, and it actually looked at AI diagnosing and providing treatment, a treatment plan alone and with a human, or just a human, and they looked at error rates specifically. And remarkably, what you said is exactly what I would have thought, that the AI plus the human is going to be the best. In fact, that wasn't the case. The AI alone had the fewest errors. So I don't discount what you said, because I agree. It's not like tomorrow that does it. We're switching over to AI entirely, but it is interesting that humans are so prone to error, and our processes are so prone to error, that we kind of live in this false belief that we do this great job and AI maybe can assist us, but we already do this phenomenal job. We have to prevent the AI from screwing up, when in fact, that's not really the case. So it's going to be interesting. Probably insurers are going to be making that decision for us, right? When they're willing to take on the liability of an AI taking a more active role in diagnosis and treatment planning.
Very possibly, but I don't see that happening anytime soon.
Yeah, I think you're right.
Think you're going to have human in the loop for a really long time.
I think you're right. Yeah.
One follow-up, something you said, does a human review every message, or is there some kind of deflection filter in front, and then they're responding to when it's a clinical area, or is every message getting reviewed?
Right now, it's every message. You don't have to set it that way, but right now we have it set so at least the MA will see it.
Nardeep, any comments on we started in digital tools, but quickly evolved to AI, where a lot of the tension in the market is, for sure.
Yeah, I agree with what the team is saying. I think AI is great for reduced admin burden, and we've seen the results also here at Renown. We'll still have some time before AI takes a bigger role, just healthcare. That's just the nature of it. I do see, I follow a lot of the studies on AI and how they're using the data that we have right now to modify the language models into making them more of a reasoning language model instead of just prediction learning models. So I think we have a lot of cool things coming in the future, but again, healthcare is going to take some time, and I don't see that happening fast, but definitely it's going to be a tool that is going to help not just providers, but also, people in customer engagements, people in marketing. It's going to help you have a larger reach and be able to, analyze different data points and be able to provide better user and patient experience.
We touched a little bit, but drilling down on ROI a little bit, wanted to ask the panel how they're measuring ROI for experience specifically, and then building consensus through leadership team, and like ultimately what does success look like, and then high level kind of what are the metrics, and does everything need to be justified with an ROI business case? It's a little bit open-ended, but I think everyone's nodding. But Jeremy, you want to maybe kick off?
Take a stab at it, Justin. I mean, this is a tough topic and there's no easy button for this. I think the reality is, yes, everything has to have a business case that's justifiable. The way you measure these things, in my experience here, is highly variable because we're doing different tactics for different audiences. But we have to be able to, if you can't measure it, it doesn't matter. Like, you have to be able to demonstrate what is, scientifically demonstrate, because health systems, we like the data and the science. So you have to do that here too. So prove it. We tend to do pilots, and I know people have death by pilot, so we're careful about how we define it, but define the scope of a pilot, define what exit criteria or failure criteria are going into it. That way it's not subjective. That's a key thing that we've learned, and that's easier said than done sometimes. With my own team, my own budget, we try to, things that we have real passion for, we think this is a no-brainer, we will fund that at least centrally for a period of time, like put seed money into it. We have partners in innovation, other parts of the business that we can build funding consortiums around when we need to, because some things, to Crystal's point, are really expensive. I make the medium bucks, not the big bucks, so I can't afford all those things. But if you find friends who have the same goal, you can have common metrics, common measures, and then prove it. And the tricky part to me is the failing forward, because in healthcare, it's do no harm. Big tech companies say move fast and break stuff. We have to kind of reconcile that. We can't break things because people's lives are at stake. But there are large parts of the experiences we touch that are more business oriented, that we can experiment, we can fail, we can learn from. And so we have to do more to infuse that culture of learning. It's only a failure if you quit and give up. If you learn and do better, you're getting, that's the cycle we're trying to go for. So I wish I had an easy button on, hey, here's a template for a business case, here's a pro forma you should use. It's not that easy. And this is probably the question where I personally spend more of my time, because in the current environment, we're all under increasing financial pressure. We have to prove it. And so as business leaders, we've got to do that. That's just part of the job.
I love that comment about break stuff. That's so true. I have not heard it positioned that way in terms of healthcare, but you're right, there is a little bit of friction there. Craig, any thoughts on ROI?
Yeah, I have a lot of thoughts on this. At the top, this is going to sound more critical than I intended to, but there's a lot of talk, even board level goals around patient experience, around physician experience. But if you look at the way those things are funded versus the financial side of the house, well, you're going to see a massive disparity. So I think we still, just from a very philosophical level, we have a lot of work to do in raising the importance of patient experience and physician experience, so that it's funded and prioritized really highly. We do, luckily at Honor Health, it is a very high priority, and executive teams have started to fund it in a way that reflects that makes that an actual true statement. But it's still, here's the crux for me, is we place a high priority and importance on patient experience and on physician experience, but I still have to do my job to fund my hobby. I have to show ROI from marketing activities, increased patient volumes and associated revenue. And we have very sophisticated models to determine that, to track that, and then attribution models for how much credit marketing can take for that net revenue from the patient interaction, not just the initial appointment, but downstream as well. And as long as I can prove that and keep getting more budget, I can funnel more to patient experience activities. Now, that's not 100% true. I would get funding regardless for patient experience stuff, right? But I can add more as I prove more ROI on the revenue building stuff, because I still haven't found a way, and I would love thoughts on this, to tie patient experience very concretely to revenue. You have a lot of not causal, it's, you know, correlation versus causation, a lot of correlations, but I have yet to find causation, and that's
Craig,
been tough.
you guys use share of wallet? Do you ingest share of wallet data to talk about market share and things like that?
Yeah, we have lifetime value and we have share of
Yeah.
wallet that we measure. And, you know, Press Ganey, we use Press Ganey for our HCAPs, our CAP surveys, and they have a lot of, they have tried to make that tie, right? But again, it's more correlation than it is causation. And that's,
Craig, do you guys use control groups or like, you know, AB in that situation to compare different cohorts?
yeah. Have you found that to be effective to show the,
Mixed bag. I mean, I mean, you're exactly right. Some of these are indirect, like directional ties, but you know,
yeah,
we tend to ladder up to either unique patient growth, which is a combination of acquiring a net new customer or building more loyalty with the current customer, and the share of care tends to work in the latter. Like many of you, we don't support 100% of the healthcare delivery model, so we are sort of focusing on the areas we have access, have capacity, and then once we do that, how do we measure the marketing campaigns, the marketing tactics to actually demonstrate, yes, you know, like you mentioned earlier, like the pop health, you know, closing gaps in care, we can demonstrate with control groups, if we have a patient who's in a journey via our marketing automation, they're far more likely to convert. And that has both a financial outcome and a community benefit pop health ACO outcome. We report that data far and wide. That's
that's interesting.
the most success we've had is those types of examples.
Oh, I hadn't even thought about that, Jeremy. That's a really good example.
So
I'm gonna chase
do a
that down.
control group. Like, for example, I think did you mention mammography? Was that you or Crystal? Somebody
That was
mentioned
Crystal.
mammography. So
Yeah.
do a cohort, track the patients who are on that journey, get those outreach, those nudges, and then have a cohort that's, again, a sufficient sample size. Do a cohort who does not get that, and you can compare. And we've done that for multiple years. We see a radical difference in closing that care gap and conversion for those on it versus off it. Now, do we take credit for that? I mean, you guys understand we're all in health systems. We don't get to say, oh, you know, pound my chest. We did that. But we all have a common goal here. So it's kind of just like motherhood and apple pie. Yes, we think this is a good approach.
That's a great approach, Jeremy. I like that. We've looked at net new MRNs and patient retention. How many have we
But Craig, you
retained?
don't have duplicate MRNs, do you? That would never happen in your EMR, right?
Oh, right. I didn't say, did I say
Never.
MRN?
Okay.
No, we would never do that.
I assume not.
I think the
Right.
bottom line is you have to measure it in advance before you ever start any kind of initiative, and then know what you're going to measure when you make the change. And when you talk about trying to do that, I mean, we have an RPA that schedules appointments. You can schedule appointments from the web. Eventually, we're going to have a new transparency model on the web where you'll see what appointments are available before ever having to go into the EMR. And then we also have a voice bot that'll be able to schedule appointments. So who gets the thing for how many appointments they schedule, right? So we actually have every vendor tagging the record that is scheduled so that we know that it was the voice bot that scheduled and they scheduled X number of appointments. And when we send out the outreach and they cancel and reschedule, it was the outreach that did the appointment. Or if it was from the website, it's going to be this one, as opposed to those people that are just in MyChart and they're going on their own because they love MyChart and they schedule there. And that way we can see what tool is doing what and how much impact they have. The other thing we do is
You're spot on there. Spot on.
yeah, the other thing we do with those experiences is like, you know, both from the phone, like on a scale of 1 to 5, how was this call? Not everybody does. Some people just hang up because they're like, I'm not answering some stupid survey. But we do get a lot of people that do, and 4.4 out of 5 people like the experience on the phone. We have people that don't like it. They don't want to talk to a bot and they're angry, and we hear about that too, and that's fine because everybody has their thing. They want to talk to Julie in the office. They really don't want to talk to an access center or a robot. But, you know, even when we send out, you know, please pre-register, they get the choice of thumbs up, thumbs down. And then they can put in comments if they want to. Not everybody does, but the comments that we get are really, really good. And that's what we iterate on. You're sending me too many messages. I have 3 appointments this week and I've gotten 3 different outreaches. Oh, we can fix that. We can send you one outreach for all 3 appointments. You can log in once, you're done. Wish this was in a different language. We made it in Spanish. So now we get comments back in Spanish that, we translate and go, this was a good experience. This is so much easier. Thank you so much for doing this, that kind of stuff. So there's the, we got a 4.5 on the phone, but we also got these many comments that said good things. And these are things that we're going to take back and work on. And so there's the qualitative and the quantitative that you have to think about when you do these types of programs.
Interesting. We're trying one other thing that I'd love your reaction to, the 3 of you as well. With GDPR and other regulations that are coming down the pike that make it more difficult to track, and understandably, I understand why, how important privacy is, but it's made it more difficult to track what customers and patients are doing on our various tools. So we're just about to sign with a company that will sign a BAA with us, and they will run everything through them. So the Google paid search and any other method we might use to track will now run through this third party who will sign a BAA. So it allows us a little more tracking, but still guarantees the privacy and is HIPAA compliant. Have you attempted similar things?
We have, Craig. I mean, that's a topic that was really du jour about a year ago. And so there are different approaches. I think, some are more conservative than others. Some have gone thermonuclear and ripped everything off. We've tried to stay contemporary and keep abreast of litigation and current guidance. And so it's a moving target. There is the reality.
Interesting. Yeah. Nardeep, any thoughts? What have you done to still track but maintain privacy?
It's challenging for us, to be honest with you. We took down all of our tracking, and part of what I'm doing is talking with operations and leadership on HIPAA compliance tools that will help us with analytics. On the marketing side, we have analytics, for that our analytics team utilizes, but it's complex. I think what Crystal said, it's good to have a plan, right, and measure before and after. And what we do at Renown is we have to get creative sometimes and try to pick a little bit of data and information from different areas. I have, we have surveys, we have a survey for our patients, we have a survey on our website, and then again, talking to operations in different departments so that we can build the story and try to understand, what's effective and how we can track ROI, but it's complex, it's hard.
Crystal, I saw you shaking your head, I think, on the GDPR, on the privacy topic. Where are you guys at on that?
I can't answer that because that's a marketing piece and that doesn't hit digital transformation. So to be quite honest, I know that we're being very careful. I know that, things you used to be able to do in Google, you could be able to tell where they are, where they're going afterwards. We can't always do that anymore. When we start doing, website stuff on our phones and Apple starts locking things down so you can't see stuff either, you lose the trail. And that we had really nice little rabbit trails of where people were. So we could go, oh, you're going here and here. We're redesigning our website now. So I know we'll be very careful and following those things. But I in that topic specifically, Justin, I don't have a good answer.
Okay, it's fair. We're on the last kind of topic we want to talk about, just kind of a little bit of a catch-all. We'll go around the room, any other insights, processes, tool sets that we haven't mentioned yet that were key factors in building out your experience strategies or roadmaps? And maybe Jeremy will kick off with you.
Happy to, Justin. So I think I'll take it back to kind of square one. I think fundamentally, I'm not a brand marketing wonk by background. I'm more of a digital guy, but I firmly believe your brand is largely just the series of experiences you offer your customers. So if you think about it that way, the marriage, it's like chocolate and vanilla with the marketing tactics and the experience tactics. So if and I would say this to folks on the line here, if you don't have alignment between what you're doing on the marketing side and what you're doing on the experience side, I would probably recommend to blow the whole thing up and start over again, because you can't do that. Like you're diverging there. Your customers, what they're experiencing every day in and out of your care sites, with your portal, with your phone calls, your call center, all those things, that's your brand. Your brand is not just the advertising or the billboards or the QR code on the bus. It's the actual experience you're delivering to your customers. So don't ever forget that.
Yeah, I can tie into that really well, Jeremy. I agree with you. And I think the thing that is a struggle is as we plug things into our websites, or we have an app versus what when you go into my chart versus what you have on your website versus, even the way that you present papers on the walls in your care sites, that all has to feel the same. And I think the more digital tools that we add on, all these software vendors are so proud of their stuff. They want to have their logo on there and they want you to know that you're using X, and that's different than the EHR. And that, at the end of the day, I don't want my patients to know that we're using X or this EHR or that EHR, because guess what? They're not buying it. No one is choosing a health system because they have this EHR. They're choosing it for that patient care that Jeremy was talking about. So what I want is them to feel my healthcare system wherever they are and have it look the same. And I don't want some software vendor who thinks they're really cool and their screens are orange. That our colors aren't orange, so that doesn't make any sense. And if you're leaving my website, which is predominantly blue, and go into orange, it is very disparate. It does not match anything else we're doing. And that even goes for the outreach back. We have several different systems that send a text to Jeremy or Nardeep that says, hey, this is something that's happening with your care. And if they don't look this same, patients are starting to go, wait, did this really come from my health system? Should I answer this? Because it doesn't feel the same. And so we have to be very, very careful about how we present our brand in each one of these tools. And that takes some talking to vendors as well to go, wait, no, we're not gonna put that up until it feels and matches the same way.
That's right. Nardeep, any? Sir?
I think Jeremy and Crystal put it in a good way. It's I manage the web team, so it's really focused on digital. But yeah, just having that effortless integration and walking your patient through different touch points and making them feel that it's the same. It's still a work in process. Like you said, there's a lot of companies that want to put their name in there and they want to manage the colors. And actually, I went through something similar to that, but just keep focusing on having that customer experience and making it easy, make healthcare accessible and easy. I think that should be our compass when we're making all these decisions and trying to integrate everything on our tech stack.
Greg, any?
Jeremy said he's not a brand guy, but that sure sounded like a brand guy. And I'm 100%.
I'm wearing the shirt, Craig. Okay, I never
Good
turned
for
down
you,
free
man.
clothes.
Yeah, I was gonna say similar to brand, that how much culture matters. And you've heard it your whole career that relationships, especially the higher you get in the organization, the more that relationships matter. And I think that is absolutely true when you're talking about customer experience and physician experience. Is the culture is really, it shapes what the patient will actually feel and experience. So if you're focusing so much on tech and processes that you are negating brand, to Jeremy and Crystal's point, but also the culture, how we behave and specific behaviors at specific parts of the patient journey, that has to be at least as much of a focus as the tech and processes, because that's what tech really should be in the background, right? We want it to enable care, to make it easier, better, but not to be in your face. We want it to be in the background. We want humans to be front and center. And that's where the training around culture, the training around brand and experience matters so much. And you'll fail if you don't put a lot of emphasis into that.
Yeah, I'll speak for Jeremy. Jeremy is Midwest humble, so
I'm a Hoosier, Justin. I can't help it.
that's right. It's a good trait. Well, I was going to wrap up some final thoughts and take questions. There was quite a few questions submitted, but anybody have any final thoughts of that last question? Kind of, I think some folks had opportunities to give final thoughts, but open the floor up for final comments from everybody, and we'll take a few questions. Anyone has any?
Oh, let's do questions.
All right. You'll be able to guess which questions were submitted from health systems versus vendors, but I'll let everyone make their own. I'll start with an obvious one, but the question you see all the time, like, what do you think you'll invest in the next few years? Kind of what's I'll say exclusive of privacy, which everyone knows that's always top of mind, security and privacy. It has to be for obvious reasons, but other than that, what's kind of top of mind for evaluation and investment over the next few years? Anyone can jump in.
I would say a couple of things. The security and privacy stuff, yes, I told you we're looking at vendors right now for that, expressly that. How can we do appropriate tracking but still maintain privacy and security? But I would say a couple other things. AI is going to be huge. We talked about it. Through our EMR, Epic, and otherwise, we're going to invest a lot in AI and its ability to improve the experience specifically for physicians and for patients. The second thing I would cite is tool integration tools or other tools that enable us to be EMR agnostic. We only have a third or so of our medical staff that is employed and therefore in the Epic environment. Most are not. Most of our medical staff are on a variety of EMRs. So we have to think of the patient experience more holistically and accommodate other environments outside of our EMR. And so we're going to invest in tools that enable us to do that, EMR agnostic scheduling and virtual visit and other similar tools.
Right.
Yeah, Justin, I would echo that. I mean, we're doing a lot of rationalization. I mentioned earlier, like we have so many point solutions. We have so many big vendors who are doing platform plays right now. And so it's always very difficult. Like I've got preferred vendors, my partners in IS or finance or RevCycle have their preferred vendors. We have to come together as a group with common goals and really figure out who are the winners going to be? Because we can't have, to Crystal's point, I've got about half a dozen texting platforms that we use for different use cases. That's not going to work. So we have to rationalize that. We have to make some bets. I think systems are having to pick winners earlier, like the days of like multiple conflicting vendors. That's not going to happen. We can't afford that anymore. So it's pick the platform players and then solutions that help us stitch together the experience. Like I mentioned, the proactivity, like we want easy button, to Nardeep's point. We want seamless, consistent, predictable across our entire footprint. I've on other calls used like the pogo stick in the junkyard or the dumpster is like the current experience. We have some good spots and some bad spots. We have to do more to make it good across the board consistently.
I'm stealing that, Jeremy. That's awesome.
Please, I
Pogo
don't have
stick
rights
in
to
the
that. Take it.
junkyard.
All
Is
of
that
you
a
take it, please.
Hoosier? That's great. Nardeep?
I agree with security analytics. It's something that we're working on right now as well. We're betting some options for us, AI, and I think another important investment should be in the training of our team. We have different solutions and different options on technology tools, but all of them are really customizable. So sometimes, it's hard to hire somebody to come and do the implementation for us. And we have implementation partners, but that can be really cost throughout time. So something that I want to focus is investing in my team on, training them in different technologies that we bring on board so that we can continue the growth and taking advantage of those tools that we're bringing in. And also, with AI being such a big focus, how can we prepare our teams so that they can utilize these tools and, take advantage of them throughout the time?
Yeah, I agree with everybody. I think, all of these things are on the horizon. We're all looking at that, but also, we're still trying to rationalize what we have and dive deeper with the partners that we have and the platforms we're already paying for. We have some platforms we're paying for things. There's use cases we can't plug in because we don't have the time, either our time or IT's time, to actually turn them on fully. And for the number of vendors that always call us and have this greatest new solution, first of all, working with healthcare is a long process. It's 2-3 years before we're going to do that. So, and we have to have a champion and a reason. We're not just going to buy tech for tech's sake, especially now when we talk about it. There was a question in the chat about provider burden and all those kinds of things. They have too much on our plate. We can't keep putting stuff on there if we're not taking stuff off. So we really have to know how, where, when, and what the choice is with the ROI things and the type of stuff that we've talked about in order for it to even start thinking about where we'd invest in something new.
Perfect. One last question, speed round. So the question probably is the answer is probably both or some variation, but you have to pick one or the other. Focus on patient acquisition or retention, Jeremy. One or the other.
I think more retention in the short term. I think as things open back up in the future years, we'll get more back to acquisition, but we have to do a better job of better treating the current patients we have. We're already busting at the seams, so we can't dump people top of funnel if we can't treat them mid funnel or bottom funnel.
Right?
We focused on acquisition and counted on my area on acquisition and counted on other areas that providing such a great experience that it leads to retention.
Right?
I would say retention. We think about cost and business investment. I think it's more cost efficient to focus on retention. And then, you know, as you say, if you have your customers happy, they'll tell other people, and then you'll grow from there.
And I'll say acquisition because we're very worried about access. And so we may be using it for ortho, but then who's their primary care? That's an acquisition to another branch. And so if we're doing it right and we have access and we have open schedules and those kinds of things, the patients will know that they can count on us for everything and all of their needs. And so we're trying to access them into other areas of our system.
Awesome. Well, we're at time. This has been great, super informative, and I see from the chat a lot of interaction, and it got through like a fraction of the question, so a lot of interest. I want to thank everybody again for taking the time, and I'll hand it back to Daniel.
Thank you, Justin. I'm sure the audience joins me in thanking you, Crystal, Craig, Jeremy, and Ardeep for that terrific discussion. And thank you to everyone in our audience for taking the time to join us today. Please note that if you asked a question that we weren't able to get to, we'll do our best to get a response to you. We'll also be sending out a link to the webinar recording, so watch for that within the next few days. That concludes today's program. We hope to see you at future forum webinars, as well as the Healthcare Marketing and Physician Strategy Summit, April 30th to May 2nd, 2025 in Orlando, Florida. Please visit the forum website at healthcarestrategy.com to learn more. Finally, be sure to give us your feedback by completing the evaluation survey as you exit the webinar. Thank you and have a great day.